Yes.
So, Dr Gunson, I'm going to ask you some questions now about the National Medical Register. Can you just tell us what that was?
Yeah. Before around, I don't know, 1990 or thereabouts, every region in Scotland had its own system of maintaining their donor records. So a donor that gave blood in Aberdeen wouldn't be known in Inverness or anywhere else. And therefore it became clear that some people could, for example, donate in one place trying to get their HIV status, for example, and then go and give somewhere else without being known that they're positive in a different region. So the National Medical Register was a way of putting people on this register who were either high-risk people, or because we wanted to make sure that confidentiality was maintained, and therefore if a name cropped up on this register, it did not necessarily mean that you were in a high-risk group. We also put other donors, a few donors, that were also permanent deferrals. So these were a group of donors who were permanently deferred, some that were partaking in high-risk behavior, and others would have been permanently deferred for other reasons, like myocardial infarction, for example. So this was a way of ensuring that if your name was put on the National Medical Register, wherever you gave in Scotland, your name will come up. And therefore, if you gave in Aberdeen and you were found positive, and you tried to give blood in Glasgow, then you were identified. The way that this was managed was, it was not an automatic process. So every week, a named consultant would know because obviously he'll be reviewing the medical records of donors, and those that would fall into this category would update the National Medical Register of his region. So if I was in Inverness, I would put one or two donors, for example, on the NMR, the National Medical Register. From that point on, those donors who gave anywhere in Scotland would be identified. And we had codes, which I can't remember. So, for example, code 1 was high-risk behavior and code 2 wasn't. So if somebody in Glasgow then identified this donor, would immediately know that this person was high-risk or not. So this was a way of ensuring that whilst the donors were, whilst all the records were still regionalized, people who were in high-risk behavior could not give blood anywhere in Scotland.
And if we just look at a paper just to get a bit of detail on it, it's SBTS 40449_008. SBTS, yep. Yes, okay, so this is, at the top it says National Medical Register. We don't need to turn to page 3, but at page 3, your name and Marie Thornton's name appear as the authors of the paper, and it's dated the 17th of February 1992. Can you just tell us who Marie Thornton is?
Marie Thornton was the National Donor Services Manager.
And you set out there what the purpose of the register is. Primary purpose is to prevent transfusion of blood or blood products from people in the following categories: those donors who have themselves declared they are in the high-risk HIV categories, whether or not the blood has been tested; those donors who have been confirmed positive for syphilis, HBsAg, HIV and HCV; those donors with a proven history of cancer; and then secondary, to prevent such persons from donating, to prevent donors who may place themselves at risk by donating to donate. And then it says this: it's acknowledged that 1.2.1, i.e. those to prevent such persons from donating, should not be pursued until such time as microcomputers are in use at all sessions throughout the SMBTS, and 1.1 above is known to be working effectively. So is it right that in fact it was rolled out in 2 stages? The first was because there wasn't the facility at the donation session to stop them from actually donating. The first priority was to make sure that once they donated, the donation wouldn't be transfused. And then only later, once you had the hardware, the computers at the sessions, could you actually stop them from donating.
Correct, because obviously, if you stop a transfusion from being given, then you have achieved your goal, that blood has not been given. As a secondary point, then yes, if you had computers at sessions, you can actually prevent the donor from actually donating blood. So you would then be preventing your secondary risk, if you like, of potentially exposing staff who are handling that blood.
Now, we know from other documents, which we don't need to go to, but I can give the reference to the transcript, SBTS 40479_005. We know from that document that this National Medical Register was introduced on the 28th, or had been introduced by the 28th of April 1993. Can you recall how soon after it was introduced, and presumably that primary function came into play, that the secondary function with the computers started to operate?
Good question. I cannot remember when the computers were taken out at sessions. I cannot recall.
Do you think it was when? Can you remember whether it was during your time at all? Was that when you were in Inverness, perhaps, or in Dundee?
Yes, I think it was. I think it was. I suspect it might have been when I was in Dundee. Cannot be 100% sure, but I guess it would have been 96, 97, something like that. I can't really remember.
And then the rest of that page sets out some of the detail you've already told us, but if we could go over the page, please, just to pick up on a couple of points. 3.6, it's mandatory that there's written evidence to support placing someone on the National Medical Register. In the case of hearsay evidence, it's incumbent on the named officer in charge to pursue evidence from the donor concerned before placing him or her on the register. If all reasonable attempts fail, then the donor's name should be put on the register. 3.7, it's recommended that an appropriate comment is put on the donor record, which will alert the session staff should the donor attempt to give blood again, but will maintain confidentiality, e.g. donor is permanently off service and has been advised not to donate, and that's the point you were raising earlier. And then just at 3.11, all donors placed on the register must be given a simple and brief letter explaining why they, and if applicable, their partners, must not donate again. And do you recall those provisions working in practice?
Yes. We were very careful that before you put somebody on this register, you had to have clear evidence that they were high risk. We could not rely on simple hearsay evidence. Somebody might not like a person and come and say, Joe Bloggs, is a drug user when he's not. So we had to have reasonable evidence, either from the GP, for example, or by asking the donor himself sometimes. So definitely people that were put on the National Medical Register, we were pretty certain that they were in a high-risk category or they had a permanent condition which would debar them from donating. I cannot recall instances where we put somebody on the NMR without having such evidence.
And was, in your view, was it a successful system? Did it work well?
It did. I think it did function a couple of times. I'm sure that there were people where, I got a notification that somebody, say from Inverness, tried to give blood in Edinburgh or vice versa. So it definitely worked in practice.
And is there any reason why this system couldn't have been implemented earlier than it was?
I cannot think of a specific reason as such. No, I think, having been very alerted to the fact that, first there was HIV, then there was hepatitis C in 91 and so on, then you begin to think about how to make the system more and more secure. And the realization that the donor records were regionalized, then we thought of the idea of saying, look, we must make sure that we prevent these people from donating anywhere in Scotland. So I presume if we had thought about it before, we could have done it earlier. It's one of those things where we thought about it, we did it, and it was implemented.
I'm going to ask you some questions now about the Standing Advisory Committee's work on the Red Book guidelines and indeed guidelines in the Scottish A to Z guidelines. So starting first of all with the Red Book, could we have please NHBT 005 4484 underscore 003. So, in fact, can we turn to page 40 of that document, please? So here we've got guidelines for the blood transfusion service. And if we turn over the page, we can see 1993, second edition at the top there. And then if we turn over to the next page, we can see preface to the second edition, and we can see that is signed by W. Wagstaff, chairman of the UK BTS NIBSC Liaison Group, and his forward is dated October 1982, if we go down the page there. And then if we carry on over the page to page 43, we can see the contents. And if we go over to page 44 and the various different chapters there, and if we go over to page, oh no, it is, sorry, section, sorry, beg your pardon, page, the page before, we were on the right page there. Selection, we've got there chapter 1, selection of donors, and then various different subheadings. And then if we turn, please, to page 62. In fact, we better go to 61. Annex 1 sets out current membership of the various different liaison groups and groups contributing to the guidelines. And if we go over the page to page 62, we can see there the Working Party on Donor Sessions, and we can see your name down there. As from Aberdeen, and is that the Standing Advisory Committee, or is that a separate working party?
No, I think that that working group became the Standing Advisory Committee.
So that rather long-winded introduction was to just orientate us in this document and to understand the part that you played in drafting, as I understand it, those parts of the guidelines that were concerned with donor selection. Is that right?
Yes, I mean, there was in the Red Book itself, which is this document that we have in front of us, it was made up of a number of chapters, of course, and the SAC, each SAC, was responsible for drafting that chapter. And in that chapter, there were broad guidelines, general introductions, principles, how a donor is treated, he gets his hemoglobin checked, and then a medical assessment, and then, whatever. And then there was also the alphabetical index, if you like, of the common medical deferral conditions, the donor exclusion criteria. So there was this chapter in the Red Book itself, which discussed the principles of how a donor is bled. And then there was a separate document, which is the medical selection criteria and actually there are 4 or 5. There's one for whole blood donations, one for bone donors, one for stem cell donors, etc. And they go into the specific detail of conditions, common medical conditions, on which a decision needs to be made whether a donor can be accepted or not to give blood.
And so we can see, if we turn then to page 69, we can see at 1.5 conditions necessitating temporary deferral or qualified acceptance, and we can see there the A to Z, the beginning of the A to Z guidelines. Is that what you were referring to there?
Yes.
And if we go over the page, we'll see hepatitis. Sorry, you were about to say something.
I was just going to say, in future editions, then these conditions became a separate document.
And then if we go over the page, we can see what it says about hepatitis. Halfway down the page there, hepatitis confirmed, review 12 months. Now I've lost it. Review 12 months from recovery. And then if we go over the page to 72, we can see the detail of what's said about hepatitis under the infectious diseases category. And so this this section of the guidelines was to be used by the medical officer to work out what should happen when somebody declares hepatitis. Is that right?
Yes, correct.
And we've got there, individuals with a history of jaundice or hepatitis should only be considered as blood donors 12 months after recovery from the illness. At this stage, approved tests for HBsAg and anti-HCV should be negative. The presence of anti-HBs does not debar, and then goes on to talk about risk groups being those who've received transfusions, acupuncture, and so on. Can you recall the discussion about hepatitis and why it was that the decision was made to allow those that had suffered from hepatitis B at this stage hepatitis C potentially, although I don't think they would then be negative, but hepatitis B to, if they'd recovered, to donate?
I mean, at this stage, we're talking about hepatitis B, and the criteria are very tight. In that one, you have to have a complete recovery, which means that sometimes you can have a chronic hepatitis where you either have low level of HBsAg, and in particular, if you've been in contact with hepatitis B, you develop what is called anticore antibody, which means either that you've been in contact with the virus, or more importantly, that the virus is still replicating within you. So the only time that you could accept hepatitis to donate blood again was that the HBsAg, the antigen itself, had to be negative, and tests for hepatitis B are now extremely sensitive, so they can pick up very, very low level antigenemia. You have to have anticore that is negative to make sure that you have got no chance of having viral replication. And most importantly, you have to have a very high level of antibody, anti-HBs, because anti-HBs is a neutralizing antibody. And therefore, if you've got, I think the level is 100 units per liter of anti-HBs, 100 international units per liter. If you've got that high level of antibody, then you are immune. Then there is no chance of you getting hepatitis B again. And therefore, in that case, it would be quite safe to give blood again. There has been over a year, at least minimum of a year, before you can give blood.
And can you recall whether the consideration was given just to simply debarring anyone that had hepatitis from being a blood donor?
Oh yes, you can debar him for many reasons. If, for example, he's still seeing a doctor about his condition, that whatever the markers are, we wouldn't even accept him. There are conditions, for example, when you know that you've got hepatitis A, then in that case you could. But even in the health check questionnaire, it does say if you've been in contact with jaundice recently, if you're still seeing your doctor about any condition, that they would be debarred. So this is not, please come back and give us blood. But if somebody had hepatitis B, is fully recovered, and wants to keep on donating, then he or she will be allowed.
But why not just say, well, actually, if you've had an infectious disease like hepatitis B, even if all of your tests come back saying that it's safe, why not debar them from donating?
In this condition, we can be really certain that that patient is not infectious. If you've got a very high level of anti-HBs, which I think even till now is compulsory to have, you have to have very high level of anti-HBs, which is a neutralizing antibody. So there's minimal chance or no chance of the virus being there, because if there's any virus, it's neutralized, and therefore they can donate. Plus the fact, of course, that some of these patients, donors can donate anti-HBs plasma, because they have very high level of antibodies, which can be used then to treat patients.
So, and presumably that plasma would go into a sort of special section, wouldn't it? Wouldn't be going into the general pool. Is that?
No. Then the plasma will go for fractionation and produce high level anti-HBs.
But could it not be said though that somebody that had contracted hepatitis B, for example, although the hepatitis B itself may not pose a risk to the blood supply because for all the reasons that you've outlined, that it may be indicative of risks, that they are a high risk donor with respect to other infections that the blood service doesn't actually know about or screen for?
As I said, we did not encourage these people to give blood. It was not, please come back. So it was only if they either insisted or we wanted, because some people are very committed and for them giving blood is a very important ethical, social thing to do. And sometimes it was important that we get the anti-HBs plasma if they were hyperimmune. Having said that, clearly every time a donor came, they had to go through the medical questioning. If they were a drug user, they couldn't give blood. So any continuing risk clearly would debar that donor. So as I say, it wasn't a free-for-all, please come back. It was if somebody insisted, then, and that's why I think we had stated, history of anti-HBs, presence of anti-HBs does not debar, because we can actually get them for hyperimmune plasma. But if they belong to any high-risk group or there was any reason that they might have chronic hepatitis, they would definitely be debarred. And if they had chronic hepatitis even once, then they'll be debarred for good. There will be a permanent deferral. Because if you had, for example, anti-core antibody, then that would be a permanent deferral.
Can I look now at the SMBTS Donor Medical Selection Guidelines, which I think you were involved in amending or revising in 1992, which is WITN 3530083. I don't know whether you're going to be able to help us with the chronology of the document we've just looked at and this document. So the document we've just looked at, you recall, was published in 1993, but the foreword written by Dr. Wagstaff was dated October 1992. And here we've got Donor Medical Selection Guidelines with a date stamp on it of 13 October 92. Can you recall the chronology of these two different documents, which came first, or were they effectively produced at the same time?
I think also I suspect they were. My aim always was to have as much as possible identical guidelines in the UK. So very often, if the guidelines on a UK-wide basis on the Red Book Committee on the SAC were agreed, then my role was to transpose those into SMBTS documentation. So there will be, the proper logos, the proper SOPs, the proper training, and so on and so forth. But very often, they would be as close or similar as possible. So I suspect that these would be very similar to what the UK guidelines as well.
Just by way of observation, the document which you showed me, which you've taken me to the dates of 1992 and 1993, 1992 for the foreword, 1993 for the revision, the first page of it, I think, said 1994 on it, that particular publication. So can we go back to 2 zeros, NHBT 2 zeros 54484_003?
Yes, so the first page we turned up before we turned on.
Yes.
Yes.
And I think you see at the bottom of the page, if
Yes.
I'm right, if my memory is correct, it says 1994. Can we just have a look?
It does, yes.
It does.
It does, but so that is because it is the first amendment to the second edition.
Yes.
So one has the second edition, which is 1993, with the first amendment to the second edition being in 1994.
I see. So we were looking at the 1994 having been amended from what was in existence in 1993.
The document I was looking at, the detail, of when we looked at the hepatitis, that detail was in the 1993 non-amended second edition. We haven't looked at the first amendment to the second edition. It's just that happens to be the first page of that document, which is why it came up.
So we have one document with the first page being an amendment to a revision which contains the unamended following pages, or are they stitched together two documents?
They're stitched together two documents.
I see.
You've got the first amendment at the beginning of the document with the you've got the first amendment to the second edition at the beginning of the document and the second edition halfway through the document.
Yes, it would be helpful, I think, to understand and for accuracy, for me to know if I'm looking at pages in the same document which appear to be the same document under the same reference or not. And obviously in this case I'm not, but thank you. Sorry about that exchange, Dr. Galea.
That's all right.
So turning to the SMBTS donor medical selection guidelines, if we can just look at the page 2, please. And we can see that it says these guidelines are based on the guidelines for the blood transfusion service in the United Kingdom, Volume 1, Chapter 5. So that, I think, refers to the 1989 version, because we just looked at Volume 1 and it was Chapter 1 that we were looking at for the donor selection chapter. And they should be read in conjunction with them. They represent the collective opinion of the SMBTS, having been discussed in detail by all donor consultants and approved by the Medical and Scientific Committee of the SMBTS. These guidelines are under constant review to ensure that blood obtained from our voluntary, non-remunerated donors is of the safest and highest quality. There's a formal annual update, and queries and problems are to be sent to you and the donor consultant group for clarification or amendment to the next edition. Now, we do have an earlier version of this from 1990 of this document, but is it right to understand that it was this 1992 version, which was the first one that you were concerned with reviewing, you were involved in reviewing?
I cannot be 100% sure, but I think so. I really can't remember whether I was involved in the first one. I suspect not, but I can't be 100% sure.
Certainly your name doesn't appear on the 1990 version.
But this one is definitely, I was involved in this one, that's for sure.
And then you say this, then it says this, that the general responsibility, the decision to accept or defer a donor rests with a medical officer or nurse at the session. These guidelines may therefore be varied at their professional discretion, having due regard to the welfare of donors and the safety of recipients. It is expected, however, that the concepts of these guidelines are adhered to. So, was it your... I mean, these were they were guidelines, could be departed from, but your expectation was that people would stick to them.
That's correct, that's correct. In general, I think both doctors and nurses who were involved in the deferral process would rather defer if they had any doubts than not. And that's why it was like, so they were more precautionary in their approach. So if they had any doubt, I mean, sometimes I used to have discussions with the nurses, like they would have used some term, some slang term, which, for example, is used in drug addicts. And they would pick it up and they would say, we would rather not take that donor. So, you know, they were precautionary, but yes, the guidelines were there as benchmarks. So they had to adhere to them, but if they had any reason to doubt the donor or some medical condition which they haven't heard of or which wasn't on the guidelines, then they would defer. And that was the general approach, being precautionary rather than accepting donors when they had doubts.
And then if we go down or back to the document to donor selection procedures, it sets out what actually happens in a donor session. All donors are asked to read the health and associated literature. They're then asked verbally a set of questions to establish that nothing in the guidelines applies to them. These minimum questions are set out at Appendix 6. And Appendix 6 is at page 59 of the document. Have you read and understood the health check, and is there anything that applies to you? When was your last donation? Have you been keeping well? Are you attending your doctor or hospital or taking any medication? And since your last donation, have you travelled or lived out with Western Europe? Now, I don't think we've got a copy of the health check. Can you remember what that had in it?
The health check proper was, I can't remember the exact detail, but it was a sheet of paper, and it had the details of the donor, and when he, his address, his date of birth, and so on and so forth, when he last donated blood, and then there were a series of questions which were in chronological order. So, for example, in the last, have you ever been told not to donate blood? Have you ever suffered from cancer, for example? And then in the last year, have you been to your GP? Have you been inoculated with any vaccines? And then in the last month, and in the last few weeks, or in the last week. And we used to pick up the common questions like, have you been feeling unwell? Are you on any medications? And so on and so forth. Then there used to be a section on the high-risk questions, all the behavioral questions. And then they signed that they consent to their blood being, if you were a regular donor, initially, very early on, as I can remember, they used to just sign on a common sheet that they've read them, and that's it. Then, as time went by in the 1990s, every donor had to sign his own particular donor health check. And then if you were a first-time donor or a lapsed donor, then you had a personal interview. Your health check question will be reviewed by a clinical staff, either a doctor or a nurse, and he or she will go through it with you, specifically ask the high-risk questions. Are you sure you haven't been in active sex with a gay man? Have you ever had a drug user? Have you been with a prostitute, etc.? And then and then do you have any other questions that you want to discuss? Are you at risk of being in a high that you want to have a test for HIV and so on? If everything of that was clear, then they signed and they consented that their blood was tested for infectious diseases. I think initially it was just for HIV, and then it became for all the viruses that we test for. And they also consented that they will be contacted if there was a positive result, a confirmed positive result, that they will be contacted and they'll be asked to be interviewed by us, so that we can refer them for appropriate care. So that was the procedure that was followed, whether it was a first-time donor or a returning donor.
And you've just described there the interaction between the donor and staff at the session in terms of asking questions.
Yeah.
The 1992 document suggests that the verbal questions that are asked are those ones we just looked at in Appendix 6, minimum verbal questions. I know that later on in 1996 or thereabouts, the personal donor interview came in to being, and I'm going to ask you about that a little bit later on. But is it right to understand that in 1992 there was limited verbal questioning of donors, but in rather later on, a more detailed interview was introduced?
That's correct.
So if we then turn, if we can, please, to the section on hepatitis, just to get your view on how that fits in with the document we saw, the Red Book document from 1993. Can we turn to page 23, please? So halfway down that page we have hepatitis. So we have childhood, less than 12 years, jaundice, stroke, hepatitis with full recovery, accept. Jaundice, hepatitis, hepatitis B, consult nurse or doctor. And then note for nurse or doctor, defer and obtain more information from GP. May be acceptable 1 year after full recovery, provided all mandatory tests are negative. Refer to centre. History of hepatitis B or C usually debars. So is it right to read that as somewhat more precautionary than the Red Book guidelines we looked at earlier?
Probably a bit more precautionary in its approach. As I said before, we weren't looking to get these donors back. It was only people insisted that, you know, they don't necessarily have to be debarred. Within Scotland, we took the position that, you know, hepatitis B or C generally debars. However, we referred to the centre, we would do all the tests, and then if the donor wants to come back, so for example, as far as I recall, we did not call them back to give blood. We did not deliberately call them back to give blood, like ordinary blood donors would. So we wouldn't send them any call-up letters. But if, however, somebody came back, then we could accept them. After, we would have done all the tests in the centre, and that's why it says for a nurse or a doctor at session, refer to us. Then we can go and look into the history, do the blood tests. If they were negative, if there was no high-risk behavior of any sort, then we would debar that donor. And that's why it says history of hepatitis B or C usually debars, not always.
So in a sense, in the Scottish guidelines, that the starting positions are rather different, isn't it? It's a history of hepatitis B or C usually debars, whereas in the UK guidelines, it's saying, well, actually, if all the tests come back, then and are acceptable, then you can let them on. Would that be fair?
Yeah, like, not quite. I mean, like, you know, in the English one, it says the presence of anti-HBs does not debar. Here we are saying history of hepatitis B usually debars. So both were precautionary, but I suspect within SMBTS we were even more precautionary.
And then we see, and we don't need to go to these, but there are various references over the years, up until certainly 1999, to there being differences between the English or the UK and the Scottish guidelines, and that being raised and consideration given to what should be done about it. What can you recall about that?
I think yes. I mean, my role, I used to bring information from the SEC. So, for example, you know, this particular condition we're accepting on a UK-wide basis. But I had to get those deferral criteria, if you like, approved by the MSC. And in general, you know, most of the directors on the MSC were pretty precautionary. And if they had any doubt, or some of them raised any doubt as to the advisability of such an acceptance, then I think in general they would err on the side of caution. And that's why sometimes our guidelines appear to be a bit more tight than the UK ones. I mean, I had to go through, I don't know what the English did, but in my case I had to go through MSC, and they had to go through them and give their blessing to whatever was approved.
I just want to get your view on an entry in this document, JPAC 602_013. It's a minute of a meeting of the UK BTS NI-BSC Standing Committee on the Selection of Donors, so the Standing Advisory Committee, 22nd of September 1994. And it's at point 4 at the bottom of the page there, report from UK BTS NI-BSC Executive Meeting in Birmingham. Main item discussed was the standing of the guidelines, the UK guidelines we looked at earlier. Approval has been given by NBA, National Blood Authority, but concerns have been raised by Scotland in relation to lack of managerial involvement in the process. It was decided that the structure should include wide professional representation. The Central Committee includes national directors who would naturally consider wider political and financial issues. Can you recall, does that perhaps give us an insight into one of the concerns that the SMBTS had about those guidelines?
I think it just reflects what I've just said, because, you know, within the SAC, we're a group of professional consultants dealing with donor care, and therefore, you know, most of the decisions that I fully subscribe to. I had the extra step, if you like, of taking the guidelines to the MSC, and because obviously the vast, you know, the majority of MSC members were the medical directors of each region, they had input into them, and that's why you will see that some of the criteria were slightly more precautionary in Scotland. And I think that is what was being reflected in this minute, that if and I'm not sure what happened in England, but if in England, once they went to JPAC, then they were approved, then I think my concern was, or the concern was, but are you sure that you've involved all the right people that have to give their input? And maybe they did, I'm not sure.
I'm now going to ask you some questions about your involvement in in devising procedure for donor counselling for those donors who were tested positive for hepatitis C. So you were asked to form or to sit on a working party with Dr Gillen and others to consider donor counselling for those infected with hepatitis C, weren't you?
Yes.
And if we look at PRSE 40515, we can look at so we'll come back to this part of the document, which is the recommended procedure. If we could start off, please, on page 3, which is the title, Report for the National Medical Director on Donor Counselling, and it's prepared by the Working Party, Dr Gillen, Dr Crawford, Dr Galea and Dr Davidson. And if we turn over the page, we can see what you were asked to do. Dr Gillen was requested by the NMD to constitute this small working party to discuss the donor counselling and requirements of SMBTS in light of the imminent introduction of HCV testing. The remit was to produce operational guidelines for BTS doctors or other doctors engaged by the BTS in the context of counselling anti-HCV confirmed positive donors, to liaise as appropriate with Dr Harold Gunson, and to produce a first draft guideline for consideration by the directors on 14th of August, and then it sets out there that you met on the 3rd of July in Edinburgh. And then if we turn back to page 1, we can see the recommended procedure that you drew up, and you've made reference to this already in your oral evidence, but it sets out what happens at 2, donors with positive screening tests and positive confirmatory tests. It sets out the steps that need to be taken there. As soon as positive confirmation results are received, the donor must be placed on a permanently off-service status. Is that what we're talking about, the National Medical Register? Is that...
Not just, yes, but also even when we modified our computer system to the new system program called Progesa and so on, you know, you can still put patients, donors as permanently off service, which means they can never donate again. And somebody like that, some of these donors would definitely be on the NMR, yes.
And so then a standard letter sent out informing the donor that the test is positive and requesting attendance for further samples, and it says that must arrive at the beginning of the week. An appointment for initial counselling and assessment is offered at the earliest opportunity, and that must be for at least an hour. The initial counselling must be carried out by a medical officer experienced in donor counselling or familiar with the information package. The donor is informed that he or she must not give blood or carry an organ donor card, and permission to inform the GP is requested. Donors given written advice provided by each centre individually on the implications of a positive test, and that's included in this document. We'll turn to that in a minute. The donor should be given a contact telephone number for further advice, and the donor is offered a second counselling session interview within 1 week. And then if we turn over the page, we see that samples are taken for repeat HCV antibody tests and any other tests considered to be indicated. And then it sets out what should be done in relation to donors where once the second tests have come back, including consultation with the GP if permission is given for that, and referral for follow-up outside the blood transfusion service. And so then if we turn on through the document, we can see at page 7 a document called Background Information for SMBTS Medical Officers Counselling Anti-HCV Positive Donors. Now, we don't need to look at the detail of this, but this document sets out some background on non-A, non-B, and on the testing and so on. Is it right to understand that this was a document that was provided to all medical officers who would be engaging with positive donors and giving them information so that they had a full understanding of the background to HCV testing?
Yes, correct. And actually, the number of doctors who were doing counselling was quite limited. There were people who understood how to counsel donors, how to handle donors by giving them bad news, and they were all consultants who were in charge of donor care. So it was a limited group of people who I believe were very experienced in this kind of work.
And then if we turn over to page 10, we can see, this part of the document runs from page 10 to 13, but we can see a detailed document which sets out the provisions for informing the donor. And we've got there the letter. The initial contact will usually be by a standard letter. So was a standard letter provided for dissemination to donors?
Yes. Yes.
Sorry?
So I was just going to say it was sent by registered post so that it doesn't get lost and so on. There were instructions on every step.
Yes, exactly. And it's even down to the tone. It should be reassuring in tone.
Yes.
And specifically mention that the reactive test result had nothing to do with AIDS. The donor will be invited to come in for further testing, etc. And then it gives detailed provisions on the interview, the first counselling session, setting out what should happen when the news is being broken, under breaking the news. The initial news breaking should be direct and simple with the minimum of preliminary. The essential information is that one of the tests done on every donation has shown a positive reaction. Explain this is a new test, etc. And at this
I think we're dropping
sorry.
off the screen.
Yes, thank you, sir. So breaking the news, if we go down, explain that it's a new test, and this can be passed on by blood transfusion. For hepatitis C, this can be passed on by blood transfusion. And then it says at this point it would generally be appropriate to allow the donor to ask questions, but it's recommended that the following information must be conveyed to the donor at the initial consultation and preferably reinforced at a subsequent interview. And then 3 points are set out that must be covered initially. That chronic liver damage can occur and liver function should be assessed. That even where abnormal liver function is detected, the prognosis is good on the majority of cases and treatment is available, and that there is little known about the routes of the spread of the virus in the population, and that sexual transmission does not readily occur, and detailed instructions about protecting others. And then the balance of the document sets out in a question and answer form, if we can just have a look at the next page, some of the questions that the group anticipated might be asked by the infected donor, what does a positive test mean? Does it mean I've got hepatitis? And then at the bottom, will I die of this? And so on. And that goes on over for another couple of pages. And then suggested answers. So this was a document, was it, that was given to all of those who were involved in the counselling of HCV donors?
Yeah, I've used it myself, I mean, for sure.
And then if we can turn back, please, to page 5. We can see at paragraph 4 there, what it says is important to redefine the SMBTS policy on our response. So just, this is paragraph 4 of the draft report produced by the working group to the SMBTS. And the group says, the working party says this, it's important to redefine the SMBTS policy on our responsibility to the donor regarding the way in which we convey information about positive tests. The group noted a letter from Dr Whitrow to Dr Gillen in which he outlined some of the practical difficulties encountered in donor counselling in the North region. The group therefore agreed that the extent of counselling and investigation undertaken must be at the discretion of any RTD, depending on local circumstances. It is our view that our duty is to inform the donor personally, i.e. at an interview, with a member of SMBTS medical staff or another doctor recruited for that purpose. So just on that issue, can you recall the difficulties that Dr Whitrow raised about counselling in the North region?
Actually, I can on this one. I think the case was that, as you know, Inverness covers the whole of the Highland region, which is a massive area. And I think his concern was that he had a patient, a donor, who lived up in the north of Scotland, something like, 150 miles away. And his concern was that, why am I calling this donor down 150 miles to give him bad news? Why can't I do it over the phone? Why can't I? That was the difficulty that he had. It was the fact that this donor was very far away, had to come back all the way, and then travel back up with bad news. If he was driving, he could be not concentrating on on driving enough, and so on and so forth. So his question was, could he give this information, say by phone? And I think we still felt that ideally, and because this was a one-off, it was a rare occurrence. Wherever possible, there should be a meeting between the donor and the SMBTS consultant to do it face-to-face, and allow time and so on to discuss it and to digest the information. But it was left at the discretion of the RTD, of the Regional Transfusion Director, that if some local circumstances don't allow this, then the RTD could decide, look, I'm going to do it by phone or by fax or whatever means he wanted to progress along. So that was the reason, I think, why that specific issue was mentioned.
And you had experience, presumably, of implementation of these guidelines, of this policy, in 3 different centres, so in Aberdeen, in Inverness, and Dundee. What was your experience in those 3 centres as to how this was implemented?
Luckily, I didn't have problems like with distancing and so on and so forth. So either in Inverness, any counselling I did myself, because I was the only medical doctor at the time. In Dundee, shared the responsibility. There was myself and Dr. Sam Rollinson. And in Aberdeen, it was either me or Dr. Urbaniak that did the counselling. So I think they were very thorough documents. They told us exactly how to proceed, what tests to do, how to handle the donor, how to refer. So I found them very useful. And
you were able to provide interviews on a one-to-one basis in person in all of those 3 centres?
Yeah, in my case, every time, yeah.
And was there any audit done of how this was implemented in other centres that you know about?
To my knowledge, no. I mean, luckily these were relatively rare events, so it wouldn't have been easy to audit because the numbers are small. But to my knowledge, There wasn't a formal audit, no.
And are you aware of there being occasions in other centres in which the first counselling appointment was carried out by the GP or by another non-blood service clinician?
It wasn't raised. If these things happened, then they were handled by the local director. They weren't raised at MSC, for example, or at any other forum that I'm aware of.
And did you have, at any time, either in Aberdeen or in Inverness or Dundee, did you have any psychological support services available that you could refer the infected donors to?
We did. Luckily, I never had to use them. But part of the preparation of donor counselling, for every, like, you know, when we introduced it for hepatitis C, which was the one I, quite a bit about, then, yes, we asked the psychology department of the university whether there was somebody that could support us. So we always had a backup. I always had a backup, knowing if somebody was in need of psychological support, and you would notice that either by frequent phone calls, for example, or things like that, then I had somebody that could help, but I never had the need to do it myself.
And we saw in the document that one of the remit of the group was to consult with Dr Gunson. Do you recall whether that liaison, or in fact the word is to liaise as appropriate with Dr Gunson, do you recall whether there was liaison and what the outcome of that was?
I believe that Jed Gillen sent him a copy of the guidelines. What he did himself personally afterwards, whether he spoke with him or I don't know, or whether he went down to Manchester, or, I don't know.
Perhaps that's something we can pick up.
I do recollect the letter was sent. The documents were sent.
I'm going to leave that.
Well, before we leave that document, may I just ask one question and have the document back up?
PRC 40515.
The document does begin in part by saying, I noticed, that nobody knows, and this of course was before HCV testing was done across the board, no one knows quite how many people will suffer from the condition in the donor population, and the estimates were between 0.1 and 2%. So that's 1 in 1,000 or 2 in 100. When it comes to answering donors' questions, the suggested answer is that a donor be told it's 1 in 200. Now, why hit on 1 in 200 rather than saying, we don't really know, but it's somewhere around, and then you can give a figure centrally in the range between 0.1 and 2%. Can you help with the thinking behind being very precise with the donor rather than telling them what the actual position was so far as the medics knew it?
I'll try my best. The document was primarily written by Dr. Gillen. Now, we had the advantage, if you like, that Dr. Gillen's prior training was in hepatology and gastroenterology. So rightly or wrongly, we assumed that, whatever he said, was correct. So I personally didn't question that, that's for sure. And to my knowledge, we did not question that figure. I suppose he derived it from the best knowledge he had at the time. And that's as far as I can go.
Thank you.
While you were in Aberdeen, you carried out a comparison of donor deferrals between the Edinburgh and the Aberdeen Centre. Is that right?
Yes.
A study which you published, which we can turn to. Don't need to turn to it at the moment, but for the transcript, it's WITN 6931002. Can you just tell us what the overall finding of that study was?
Yes, it was a 10-month retrospective study looking at donor referrals. we were collecting data on donor deferrals all the time as part of our routine. And this was an audit which was commissioned by the Clinical Research and Audit Group as part of the audit program of SMBTS, which was chaired by Brian McLennan. And this was looking at, we noticed that the deferral rates between the two regions were quite different. So we wanted to find out how come, we're using the same guidelines. What are the issues here? What's going on? So we did a retrospective study. We tried to compare the data. So we took random samples of these deferrals. So for example, I took 50 deferrals from Aberdeen, gave them to Jack Gillen in Edinburgh, and see whether he would interpret them correctly as I did, or vice versa. And we found that the comparability was quite good. What we noticed was that there were different management systems in the two centers. So when the study was done, in Edinburgh, Jack Gillen there was already a single donor health check questionnaire per donor being asked, compared, which each donor had to sign, compared to the one sheet which everybody signed in Aberdeen. Secondly, I'm pretty sure that first-time donors in Edinburgh were undergoing a limited personal interview. So we thought, well, this is something which is obviously important. Clearly, a more direct contact with the donor is more beneficial. The donor will be able to tell you more than otherwise by just signing a paper, which he would have signed X number of times before if he was a regular donor. So that was one important finding. The other important finding was that the decision, we only looked at deferrals. So the study had quite a limited scope. We were not looking at how good the acceptances were. We were only looking at the deferrals, so it was quite limiting. But having looked at the deferrals, we found that whether the deferral was done by a doctor or a nurse or a clerk, the deferral was generally a correct one. The difference was that in the management of the donor himself. So for example, in one region, like in Aberdeen, if a donor is seen by a clerk first, and she look at his questionnaire, if she sees anything, she would refer to a doctor immediately. If she sees something of any doubt, she would refer to a doctor or a nurse. Whilst in Edinburgh, for example, she would take a decision, like if somebody says, I have a current cold, she would say, sorry, if you've got a current cold, you can't give now. Whilst in Aberdeen, that didn't happen. So we noticed that although the deferrals were generally correct, the people who were doing the deferrals were different. There was no difference when it came to medical or surgical deferrals between the clinical teams, whether you're a doctor or whether you're a nurse. And importantly, the different documentation between Edinburgh and Aberdeen, particularly the tick box questionnaire and the personal interview that was taking place in a limited way in Edinburgh, was bearing fruit in terms they were picking up more deferrals in the context, particularly of high risk. I mean, clearly there are limitations also in the fact that maybe the populations were different. Maybe the Edinburgh people were more open about their behavior or their drug addiction or whatever, compared to the more reserved people in the Northeast, perhaps. Also, one needs to remember that at the time, 1985 and so on, Edinburgh was the HIV capital of the world, or at least that's how it used to be known. So there was a lot of drug addiction taking place, and therefore maybe the prevalence was higher. And therefore the deferrals had nothing to do with the personal interview itself, but more with the background prevalence of the behaviors. So although there were limitations, I think it bore some fruit. And within those limitations, I think this audit was the seminal study which then allowed personal donor interviews to be rolled out in all the Scottish regions.
And was it another consequence of your study that donor sessions became nurse-led rather than having to have doctors present?
Yes, having seen that there was no difference in the decision-making process, if you like, between when it came to medical and surgical referrals between doctors and nurses, then it helped support the fact that we could go to led nurse sessions. It wasn't the only study. There were other reasons which helped us go down that route. One was the fact that we couldn't get medical staff that could be rostered on a regular basis. Many of the medical staff were there as part-timers who were, for example, GPs and used to do sessions with us. So you couldn't roster them properly. And therefore, it made life very difficult for somebody like myself who wanted to train all the doctors and nurses about their availability. So we had some concerns because if you don't attend training sessions and you're still being rostered, then how good is your decision-making process? Whilst a nurse employed by the blood service was always there, and we know that nurses are very good at following guidelines. So when you give them good training and you offer them the guidelines, and we also showed in the study that the guidelines were pretty good. There were very few conditions that couldn't be found in the guidelines or that a nurse couldn't interpret from the guidelines. So even though you had good guidelines, the nurses had to be trained, the doctors had to be trained, and you had to be doing the job on a regular basis. And we had difficulties in recruiting good doctors on a regular basis, and we felt that with this study, it helped us in the support of saying we can do nurse-led sessions throughout Scotland, which we ultimately did.
I'm going to leave your time in Aberdeen now and move on to your time in Inverness and then Dundee. Before we break for lunch, could you just give us a sort of pen picture of what the facilities were like in Inverness, what the role of the centre was, the challenges, and so on?
Personally, it was a big challenge. It was a big move for me from being a consultant in a centre to becoming a director. It was my first role as a director, learning how to manage people for the first time. It was a move to a smaller centre. Inverness was smaller than Aberdeen. It was still a very useful centre in the context of all the functions that Aberdeen did, Inverness also did. It was a smaller group of people, which had its own challenges because we were covering an enormously large area. And therefore, we had difficulty in getting the resources to make sure that every session was properly staffed and so on and so forth. It was also a time of a big challenge for me because a new centre was being built at the time. So I spent my first year or two was spent learning how to manage people. I restructured the department because the predecessor, once he knew that he was leaving, he wanted to retire, he just left the restructuring to myself as the new incoming director. So I restructured the department with a proper management team around me, a laboratory manager, a finance manager, a donor services manager. I appointed a new quality manager, plus having to get to know all the new hematologists, all the new surgeons, and building a new center. So, plus making sure that we don't run short of blood at the same time, and making sure that our cross-matching functions were still functioning adequately. So I was pretty busy in the first few years in Inverness.
And your statement tells us that, and we know from other documents, that the centre was funded, funding came from the SMBTS, and that budgets had to be approved by the SMBTS. So you had your own budget, but it was all approved by the SMBTS. Is that correct?
I mean, that happened in every centre I worked. That's how SMBTS functioned. CSA gave the funds to SMBTS, and then the money was allocated to us, and within that money allocation, okay, that was my responsibility, but any new service, any new appointment that I had to make, I had to get the blessing of the National Finance Director and so on and so forth. So although we had the budget, the allocations were all set. So they all knew where the money is going for, is what the money is being spent on, and the majority of it was on staffing, of course. But any new initiative, any new appointment had to be approved centrally.
And you also tell us that and you've already told us it was the smallest centre in Scotland, and you estimated that you think you took about 20,000 donations a year. Is that right?
I guess so, yeah, about that much, yeah.
And that number stayed pretty stable over the 3 years that you were there.
Yes, yes. Yeah.
And I just to ask you a couple of questions about the targets. You've mentioned previously that the targets were provided to you for donor collections by the SMBTS. So those were set centrally, were they? But you were consulted about them, were you?
I mean, when it came to donation targets, those were mostly historical. How much we collected. We were I think in Venice, we were probably a bit above average in terms of percentage of people that donated per 100 population. Normally it's around the 5% mark. So we were pretty comfortable with that. When it came to plasma targets, those were set by SMBTS, and I'm pretty sure we achieved them all every year.
And your statement tells us that you had a plasmapheresis programme was in place when you arrived at in Inverness, and that's the same for Dundee as well.
Yes, it was all machine apheresis. It was used. It wasn't a cheap option. It was much more expensive than getting plasma from whole blood. But if we're then short of plasma to reach our targets, then that was a very useful source of plasma collection. And also, then once you've got the machines, you can use them also to collect platelets. Because the staff were trained, the nurses were all trained, and therefore it was a relatively simple move then to get platelets if you had to.
And your statement also tells us that the centres, so relevant for both Inverness and Dundee, were licensed by the Medicines Healthcare Regulatory Authority, which was a biannual process of inspection. Is that right?
Yes. Every 2 years, they used to come along, spend 2 or 3 days. They used to go around, and ask people whatever they wanted to ask. And then they will give you a report with either critical deficiencies or major deficiencies or minor deficiencies. And then depending on those and depending on the time lag, so if they tell you that you have a major deficiency which must be rectified in 2 months, for example, then once you showed proof of that, then they will give you a license for the next 2 years.
So it would now be an appropriate time to take a lunch break.
Yes, it would. We'll take a break now for an hour. So allow you to have what may be a late-ish lunch for you, but it's our lunchtime here. So I'm sorry that you have to fit in with English time.
No problem.
So 2 o'clock for us, 3 o'clock for you.
Okay, thank you very much.